I see participants are starting to join us. So folks, I'm going to give it just another minute or so. I know it takes a second for folks, even though we are like, many of us are sort of still, at least I should speak for myself. I have had to run down the hallway to get from one meeting to the next here, but for other folks, I will make sure that we are giving another minute or so for folks to join. Appreciate everyone joining us on this, I believe what is now going to be the afternoon for everyone, I think, who will be joining us. So thank you for spending some time with us today. Like I said, if you're just joining, we're going to give it another minute or so, and then I'm going to move things along because we do have a packed agenda for everyone today. All right, so I think I'm going to go ahead and get us kicked off because we've got a little bit of formality in the front end here. So just want to welcome everyone on behalf of Academy Health, AHRQ, and the Scientific Resource Center. I want to thank all of you for joining us for this session of the Grand Rounds series of the Evidence-Based Practice Center program. As always, this meeting will be recorded and shared with external audiences. And as you join, if folks can please drop your title or your affiliation in the chat so we get an idea of who's joining us today, that would be wonderful. I think we're going to begin the recording. All right. So just for all of you, I am Elizabeth Cope. I am Chief Programs and Science Officer at Academy Health. Leading the meeting with me today is Dr. Lucy Savitz, Senior Innovation Advisor at UPMC Health Plan Center for High Value Healthcare, and also professor at the University of Pittsburgh's Department of Health Policy and Management in the Graduate School of Public Health, and also most near and dear to my heart, immediate past chair of Academy Health's Board of Directors. So we've partnered with AHRQ and the SRC, that Scientific Resource Center, to bring awareness to and help disseminate research findings of the ongoing evidence reports that are published by the Evidence-Based Practice Center program. And today, the reports that we're going to be highlighting focus on new research in youth and adolescent mental health. We'll have opportunities for open discussion and Q&A later on, so please, in the interim time, please feel free to use the hand raising and chat features throughout the meeting. And I think if we go to the next slide, oh, that's our note that's going to be recorded. At the conclusion of this webinar, we hope that those in attendance will have gained some insight into the learning objectives that we've got listed here. And at the end of the meeting, we will also be sharing a link in the chat to an evaluation survey required for those interested in earning continuing medical education credits, which was noted on the slide before. But so here, as far as our objectives are concerned, we want to be able to describe recent trends in the prevalence of mental health conditions among kids and adolescents, including the increase in rates of anxiety, depression, and suicidal ideation over the past decade. Summarizing key challenges contributing to child and adolescent mental health crises, such as shortages in the behavioral health workforce and long wait times for specialized care. 3, identifying the roles of primary care, school-based services, and emergency departments in delivering mental health support to youth and understanding the limitations and pressures faced in these settings. And then applying insights from recent findings to assess potential improvements in local or organizational approaches to supporting mental health needs among young people. All right, so moving ahead, I would just like to highlight a few items from our agenda. If we go back to that slide. So what we've got planned for you today, as I mentioned, is kind of a packed agenda. We're going to hear, I'm going to pass it over in just a second to my colleague Lucy, who will be introducing all of the folks that you are going to hear from today, from our report authors as well as our discussants. And then you're going to hear presentations from each of our authors. And so first, we will be focusing on the ADHD Diagnosis and Treatment in Children and Adolescents. And obviously, after each of these presentations, there will be some initial reactions from our discussants. But the second of those will be our presentation on the diagnosis and management of obsessive compulsive disorders in children. And then we'll move into management of suicidal thoughts and behaviors in youth. As I mentioned, after each of these, there will be some initial reactions from our discussants, and then we'll move into some of our discussion and Q&A space. And so there will be an opportunity. We obviously want to hear from all of you. So we hope that as these presentations are occurring, you all are thinking of those questions that you have, and you're going to have those teed up. And we'll have some discussion with our report authors, and then we'll also move into discussion with our discussants as well in that thematic focused discussion. But throughout all of this, of course, we are going to be interested in making sure that we're hearing from all of you. All right, so I am going to turn things over to my colleague Lucy to introduce our report authors and discussants.
Great, thank you, Elizabeth, and thank you everybody for joining us today. It's my privilege to introduce the report authors and the discussants who'll be participating with us. And I'd now like to introduce Dr. Susanne Hempel, who's the director of the Southern California Evidence Review Center and professor in the Department of Population and Public Health Sciences at USC. Her co-presenter is Dr. Bradley Peterson, who's the inaugural director of the Institute for Developing Mind at Children's Hospital Los Angeles, as well as vice chair for the Department of Psychiatry at the Keck School of Medicine at the University of Southern California. And also joining us is Dr. Gaelen Brown, who's a research scientist at the Brown University School of Public Health and a program manager at the Brown Evidence-Based Practice Center. Her co-presenter is Dr. Dale Steele, who's a professor of emergency medicine and pediatrics and adjunct professor of health services policy and practice at Brown University. And finally, but not last but not least, we'd like to welcome Dr. Leslie Sim, who's the Director of Standards of Excellence at the Mayo Clinic and member of the Executive Board of Directors for the Academy of Eating Disorders. I think this will be a rich discussion, and we thank them all for joining us today and describing their reports. And then next, I'd like to introduce our invited discussants. Dr. April Joy Damian is a psychiatric epidemiologist and health services researcher with expertise in health equity, social determinants of health, and mixed methods. She serves as the vice president and director of the Weitzman Institute, a national research, education, and policy center directed to innovation and impact in primary care for the underserved. She's joined by Dr. Jennifer Poon, who is a developmental and behavioral pediatrician and chairperson of the American Academy of Pediatrics section on developmental and behavioral pediatrics and professor at the Medical College of Georgia Department of Pediatrics and Adolescent Medicine at Augusta University. And also Michelle Zabel, who joins us to weigh in as an executive director on the Innovations Institute and associate extension professor at the University of Connecticut School of Social Work. So with that, I'd like to invite Susanna and Bradley to begin.
Yeah, thank you very much. So ADHD Diagnosis and Treatment in Youth. We're here from the Southern California EPC. And on the next slide, just a quick disclaimer. So we have no conflict of interest. I commissioned the report, PCORI funded it, but the following is our own opinion, and they're not an official position of AHRQ PCORI. And on the next slide, you can see this was a large project, and many people worked on it. We should say the project was initiated by the American Academy of Pediatrics, ultimately to support their clinical practice guideline. Yeah, thank you to everyone who supported the project. And yeah, with that, if we can go to the next slide. So this was set up as a comprehensive review. So for diagnosis, we accepted any tool that may have been used to diagnose ADHD, but studies had to report on diagnostic accuracy. We did also not restrict to specific treatments. We accepted all interventions as long as they were meant as treatment, and so we had to see a certain duration of it. So we also did not restrict to RCTs here, randomized controlled trials, but because we wanted to include the psychological literature, but studies had to report on a concurrent comparator. For monitoring, we had no study design restriction as such, but studies had to report on the effects of the strategy, of how successful, how useful the strategy was. For example, assessing ADHD every 6 months rather than every year. Yeah, and with that, to the next slide, you'll see that we also used a very broad search strategy. So we reviewed over 20,000 citations. We found over 200 diagnostic studies. We included over 300 treatment studies, but despite searching high and low, we could only find 10 monitoring strategy studies. Yeah, with that, I want to turn it over to Dr. Bradley Peterson, who will talk us through some of the results.
Great, thank you, Susanne. For our key question 1, it pertained to diagnosis. We found 231 included studies. You can see the categories. Most were rating scales from parents, teachers, or youth themselves. Quite a few on neuropsychological tests and other more sophisticated technological diagnostic tools. Next slide, please. So this is the performance of some of the rating scales. So we're plotting here sensitivity on the y-axis and specificity on the x-axis. The issue with sensitivity specificity, as you probably know, is that they depend critically on the diagnostic threshold of whatever tool you're using. For example, an ADHD severity score on a rating scale. So depending on where that threshold is set, you can improve sensitivity, usually at the expense of specificity and vice versa. So there's a trade-off between sensitivity and specificity, and the performance of a tool depends critically on those thresholds. So you can see for parent rating scales, the areas under the curve vary widely from fail to excellent. And on the plot, you can see in the bottom right-hand corner, you have very high specificity, but terrible sensitivity. In the upper left corner, you have excellent sensitivity, terrible specificity. Those that lie on a diagonal are kind of functioning around chance level diagnosis. And those that are progressively closer to the upper right corner perform better in terms of having both good sensitivity and specificity, which is what you generally want. So you can see there's tremendous variability across studies. There are quite a few studies. I think those are the primary take-home messages, and vast differences in performance. There are some hints if you look at what tools are performing better, meaning closer to that upper right-hand corner, but they're really too few to generalize with any confidence. If you can go for the right hand. Yeah, thank you. These are teacher ratings. So there are fewer studies of teacher ratings, as you can see, but the general variability and the same issues apply as with parent ratings. and vast discrepancies in how the tools perform across studies. Next slide. Neuropsychological tests are on the
So,
left.
Brad, I think we need to skip this one.
I understand. Okay, that's fine. Anyway, neuropsychological tests don't perform any better than rating scales. That's really the bottom line bottom line message, I think. This is another important take-home message, which is when we assess sensitivity and specificity and area under the curve, which kind of integrates across sensitivity specificity, you can see that the red curve, which are diagnoses in clinical samples, compared with diagnoses where you are comparing ADHD kids to neurotypical controls, seems to be a systematic difference across studies, in the sense that there's much better performance of these diagnostic tools when you're comparing ADHD versus neurotypical controls. Almost certainly because in clinical populations, you have disorders like depression, anxiety, PTSD, autism, other conditions that have overlapping symptoms with ADHD, especially inattention, impulsivity, and distractibility. Next slide. So conclusions for KQ1 are that multiple approaches show promising diagnostic performance, for example, using parental rating scales, but the estimates of performance varied really massively across studies, and the strength of evidence was generally low. Diagnostic test performance likely depends on whether youth with ADHD are being differentiated from typically developing kids or from clinically referred children who had some kind of mental health or behavioral issue that overlaps symptomatically with ADHD. Rating scales for parent-teacher or self-assessment as a diagnostic tool for ADHD generally have high internal consistency, but poor to moderate reliability between raters. This indicates that obtaining ratings from multiple informants, for example, youth, both parents and teachers, may be valuable to inform clinical judgment about the presence or absence of an ADHD diagnosis. Studies evaluating neuropsychological tests of executive functioning, for example, continuous performance test or CPT, they use study-specific combinations of individual cognitive measures, making it very difficult to compare performance across studies. And I'll also add that they almost never test in a new clinical sample the performance of the tests that they developed with these combinations of measures from, say, the CPT. Next slide. So we also had a question pertaining to treatment. We found 312 studies that were included. This included combined medication and behavioral approaches, medications approved by the FDA, other pharmacological treatments not approved by FDA, psychological and behavioral approaches, and then other more contemporary, novel approaches to treatment, including neurofeedback, neurostimulation, and so forth, as you can see all the way down the list. Next slide. So these are some of the forest plots, giving you a really 50,000-foot view of overall findings. On the left, you can see the forest plot for medication versus control treatments, and really very convincing, very strong evidence for strongly favoring the use of medication over controls with moderate to high effect sizes. So really quite a strong evidence base. When we searched for studies that conducted head-to-head comparisons between the most commonly used medications for ADHD, there were very few. One was atomoxetine, which is within a specific class called norepinephrine reuptake inhibitors, versus methylphenidate. We found a decent handful of studies suggesting rough comparability between them, although a trend toward favoring classic stimulant medications, methylphenidate – over atomoxetine, but more studies are needed. Next slide. Outside of just looking at ADHD symptom severity, which is what we looked at in the previous slide, we also looked at other outcomes, including broadband scales, things like clinical global impression scales and other broadband measures, effects on functional impairment. And medication seems to, as a general class of intervention, seem to be helpful for both broadband measures and functional impairment. So extending the potential benefits of medication beyond just core ADHD symptoms. Next slide. These are effects of medication on appetite suppression. So on the left is medication versus control across all studies, and really quite very strong effects showing that medications in general tend to suppress appetite. The one exception that we found was alpha agonists, which seem not to, but virtually everything else does. On the right, we have a direct comparison of amphetamine versus methylphenidate on this outcome, and essentially there is no difference, although it's a very small handful of studies and very few head-to-head comparisons, unfortunately, between the two most common stimulus classes. When comparing atomoxetine versus methylphenidate, it's very small to read, but as I recall, there's really not a significant difference in appetite suppression. They both suppress appetite, and maybe a slight trend toward methylphenidate producing more. Next slide. This is effects of psychosocial interventions on core ADHD symptoms. On the left, we see across all included studies, putting everything into one big basket, there is evidence for a significant effect of youth-directed psychotherapy versus control conditions. Effect sizes are small to moderate at best, but typically small across these studies. On the right-hand side, we have parent support interventions. So parents are the targets here, trying to help management typically of the behaviors in their kids versus control conditions. And again, there's evidence across all interventions that there is some benefit, again, of relatively small effect sizes. Next slide. Conclusions for KQ2 for treatment include several treatment modalities improve core ADHD symptoms, including medications and psychosocial interventions with high to moderate strength of evidence. FDA-approved stimulants and non-stimulants had the strongest evidence for significantly improving ADHD symptoms and other additional outcomes. Head-to-head comparisons between stimulants and non-stimulants did not detect significant differences for most effectiveness outcomes and adverse events. There's little evidence, surprisingly, that combination therapies of medication plus psychosocial therapies produce better results than medication alone. But existing research evaluated unique combinations of intervention components. Next slide. Limitations of KQ2 is that despite a large body of research, comparative effectiveness and safety information is limited. Much more research is needed to help choose between treatments. That's critical. We didn't detect differential treatment effects associated with ADHD presentation, but analysis, meaning predominantly inattentive or combined type, but studies are limited. Data were insufficient to assess the effects of co-occurring disorders on treatment effects, and too few studies reported on diversion to quantify the risk of diversion of medication treatment. Next slide. For the KQ3, the monitoring strategies, again, we only found very, very small number of studies, none of them addressing the same issues. We found 10 overall. Much more research is needed, and we'll leave it at that for now. Next slide. Suzanne?
Yeah. So this is just to say, we present this all in a very long and very detailed AHRQ report. There's also a beautiful data visualization. Shout out to Ed, who made this, which even links to individual studies. I think that's very useful. And we published most of the results in 2 companion papers in pediatrics. Yeah,
Great. Thank you
much.
very much, Suzanne and Bradley. Let's turn to our discussants now. We'll take comments from discussants in alphabetical order. So we'll begin with you, April Joy, and then move to Jennifer and then Michelle. April Joy?
Great, thanks, Lucy. Yes, and thank you to the presenters for such an insightful report. I certainly learned a lot myself. So I really wanted to speak to the first key question about this limited agreement among different raters and provide insights to that. So really acknowledging that it's multidimensional, context sensitive, and subjective nature of ADHD symptoms, which we see a lot in our own federally qualified health center, FQHC in Connecticut. And so first, really recognizing contextual variabilities of symptoms, right? So this variation across settings where at home, a child might be more relaxed or less structured, which may reduce overt symptoms. At school, so we work with, through our school-based health centers, recognizing that demands for sustained attention and impulse control are higher, so that may make symptoms more noticeable. And then in our clinical side, that the structured environment and one-on-one interactions can mask symptoms. So I really also wanted to speak to the ones who are conducting or the raters themselves, right? And so there may be differences in expectations and tolerances, which is why we may be seeing these differences in terms of inter-rater agreement. So for example, parents may normalize or minimize behavior based on family dynamics or comparison to siblings, whereas teachers observe children in structured environments and compare behaviors to a group of peers, making hyperactivity or inattention more salient, and then comparing to our colleagues, our clinical colleagues who rely on standardized questions and brief interactions and who might not fully capture symptom patterns given the limited time that they have. And then the third that I'll bring up, and I'll keep bringing this up given the perspective through which I see things, is the variability in informant knowledge interpretation, right? So the different informants, right? I mentioned teachers, parents, clinicians, and then the pediatric patients themselves may differ in their understanding of ADHD and its symptoms, their interpretation of behavior, especially when we take in consideration culture, and an awareness of developmentally appropriate behaviors, because we know that some inattention is normal for young children. Thank you.
So as a developmental behavioral pediatrician, I really appreciate that statement about thinking about what is a developmental norm. So that is a challenge, especially in younger kids, is when are these behaviors in the normative range versus when do they cause dysfunction? And I think sometimes, for some raters, that's especially a challenge. What I often think about, though, is often these are children that are coming to their general pediatricians for some sort of help. Their parents or caregivers are seeking some sort of help. And, sometimes that differential can be very broad, but when you think of a office visit in a general pediatrician's office, sometimes what might happen is those visits might occur over time. And as you're trying to tease out those symptoms over time and gather things like questionnaires, it is really a challenge sometimes to get collateral information from other sources. So I think in real life, that can be a big challenge in diagnosis as well.
Thank you. And thank you for the report. I have to say, I also learned a lot. And I don't know that I'm going to love going third because I do appreciate everything that everyone said already. I think I'll take a little bit of the, just a little bit of the neuropsych conversation that didn't get fully presented and then think about schools as well. I mean, I do think that we have a system right now where people might run to neuropsychology for evaluation, comprehensive evaluation, and that given the wait times for that discipline in particular and the inability to even get in to see them for almost a year sometimes in some areas of the country, that we've got to push this type of opportunity to other elements of our field and hold neuropsychology kind of to very complex needs. And any neuropsychologist here can discuss that with me. But I do think the more we can prepare our pediatric offices and do integration efforts, the kind of better off we are in the ADHD world. And I also would just want to throw in early on to this whole discussion the opportunity around wearables and other mechanisms to, obtain information more comprehensively from both the child, adolescent, the teacher, family. And enough has been said about the inter-rater reliability. I appreciated everything April said about the context. I think that's really important. I think one of the things that continues to concern me in this space between medication and treatment is that we're not necessarily seeing positive impact as a child gets older in their capacity to do well in school. And we have some research that's starting to emerge around that. So I just, I'm the systems person in the room and think that there's a little bit of a remake of the context that a child with attention deficit needs to walk into. So I'm, raising the idea that sometimes we need to push and use our workforce more effectively, use some technologies that we're not quite using across the board to gather information. And we definitely need to hold hands with our schools and our teachers about how to really organize classrooms that can support children who have additional needs so that their actual functionality, right? Because that's what we really care about. We really care about functionality of a child. And so how do we help that happen in what is their job on a daily basis? So thank you.
Now everybody can appreciate why we chose these discussants. This was really great observations. And Michelle, that was a really capstone presentation that brought all the comments together. So thank you very much for that. I'd like to now invite Gaelen and Dale to present their report.
Thank you for including us. I'm Gaelen, and with Dale, I co-led this report on diagnosis and management of obsessive compulsive disorders in children. On the next slide, you can see the same standard disclosure and conflict of interest. We also had no conflicts of interest for any of our team members. Again, this was also sponsored by PCORI and AHRQ through the Evidence-Based Practice Center program. And again, the findings and conclusions are our own. On the next slide, a little bit of the context. This was a systematic review with meta-analyses, specifically diagnostic and network meta-analyses. The purpose was to inform an update of the 2012 American Academy of Child and Adolescent Psychiatry practice parameter. The full report's available at this link, and likewise, the findings from this report have been published in a pair of articles in the journal Pediatrics. This report had two key questions. The first focused on diagnosis, specifically brief assessment tools that could be used in a non-clinical or non-specialist setting. The second key question had to do with treatment and the comparative effectiveness and harms of a treatment. For both key questions, we also looked for effect modifiers. The methods for this project are on the next slide. We followed standard AHRQ methodology for systematic reviews. We searched 6 databases and the reference lists of relevant systematic reviews up till May 15th, 2024. We screened for eligibility in abstract and then full text, extracted the data, evaluated the evidence both at the level of the individual study for risk of bias and then across studies for strength of evidence, and then synthesize the results. I'm going to present the results of key question 1, which was about diagnosis, and then Dale will take over from me and present the results of key question 2. For key question 1, we were really looking at children and adolescents in whom there was a clinical consideration of OCD. The interventions were brief assessment tools that could be used in a non-specialist setting to identify OCD in symptomatic patients. Comparators, in all studies, the comparator was a reference standard clinical diagnosis by a doctoral level evaluator using a validated diagnostic assessment instrument. Next slide. We found 22 studies that evaluated 9 brief assessment tools to determine whether a child should be further evaluated for OCD. All but 2 of these studies were case control studies in that they compared a known group of children with OCD to a control group of either clinical controls or a mix of clinical and non-clinical controls. We assessed the risk of bias of these studies using the QUADIS tool, and as you can see, the study quality was on the poorer side. The mean age range was 9 to 16 years old. The sample size ranged from 50 to about 2,500 kids. But these studies really had inconsistent control groups. And as you can see in the bottom row of this table, some even included only patients with OCD or had non-clinical controls. Nevertheless, we did find some information, some results that we think were somewhat meaningful. This figure shows the sensitivity and specificity, or 1 minus specificity, results for each tool, with colors indicating the specific tool used by each study. Each dot or triangle represents a tool and cutoff or cut point combination. The better performing tools are in the top left corner. Most of the brief assessment tools we evaluated were evaluated in only 1 or 2 studies each, except for the Child Behavioral Checklist, or the CBCL OCD or OCS, which was evaluated in 9 studies and is represented by the circles. The other tools are represented by triangles. Several tools, including the Toronto Obsessive Compulsive Scale, or TOCS, which is in light green, the Obsessive Compulsive Inventorial Child Self-Report, or the CHOSI, which is in dark green, and the Spence Children's Anxiety Scale, which is in yellow, appear to have cutoffs with sufficiently good sensitivity and specificity, both above 80%, based only on 1 or 2 studies. But more research is obviously needed to confirm these findings. 2 studies compared child versus parent report on the same scale, the Short OCD Screener, or SOCS. In these studies, they found that parent reporting compared with child reporting had similar or slightly better performance, but again, much more research is needed. We were able to meta-analyze the CBCL. The results are shown here. There were 9 studies that evaluated about 3,700 children. In all studies, the parents completed the entire CBCL. Then the researchers analyzed the subsets of questions pertaining to OCD. Based on this analysis, the CBCL probably has sufficient diagnostic accuracy to identify symptomatic patients for specialist referral and comprehensive diagnostic evaluation. So as a summary, which is on the next slide, the limitations were that most of the studies used a case control design. Some included only patients with OCD or had non-clinical controls, potentially overestimating both sensitivity and specificity. Few tools were assessed by more than 2 or 3 studies. We found no studies designed to evaluate potential clinical effects, such as resource use or time to treatment, or potential effect modifiers. Brief assessment tools, nevertheless, have been proposed to be used in primary care Providers evaluating youth with symptoms of OCD to facilitate early identification and specialist referral. And the CBCL OCS may be sufficiently accurate to perform this function. I'm now going to pass over to Dale.
Thanks, Gaelen. So key question two had to do with comparative effects and harms of treatments, either psychological interventions or pharmacological or combinations thereof. We prioritize 7 outcomes, but as a strength of this evidence base, the children's Yale Brown Obsessive Compulsive scale was almost uniformly used. We extracted other outcomes, but in this presentation, I'll focus on the SciBox outcomes because that's where most of the data is. Obviously, the other outcomes are important. Worth noting in passing that although our inclusion age was up to 21, almost universally studies capped at age 18. So we have nothing to say about the 19 to 20, that important 19 to 21-year-old group. On the next slide, we look for our study of comparative effects. We focused on RCTs and a few non-randomized comparative studies. In general, there were a mix of pharmacological, behavioral, and combined interventions. We did look at single-arm trials to try to identify predictors of treatment response, and really found very little to say about treatment effect modifiers. The next slide shows the interventions that were part of the network meta-analysis. This plot, the red circles are the interventions, of which there were 5 active interventions. So SSRIs for selective serotonin reuptake inhibitors, clomipramine, which is a tricyclic antidepressant, exposure and response prevention in the setting of CBT, ERP provided via telehealth, and then a combination of ERP and SSRIs. We had a lot of discussion about the control conditions, but ended up with 3: sole placebo, often used in the pharmacologic trials; behavioral control, which consisted of aspects of CBT, including relaxation therapy and psychoeducation; and then waitlist controls, patients who were on a wait list and were assessed but not given any active treatment. The size of the circles indicates the number of patients allocated to each of the treatments, and you'll note that even for the most common treatments, so SSRI had 775 participants, ERP had 542 participants, and then some of the very important nodes, including the ERP plus the combined treatments and the behavioral controls, had just over 100 to 200 subjects. Next slide. One of the outputs of the network meta-analysis is a ranking. So this is informally called a rankogram, but each histogram looks at the probability that a particular treatment or treatment combination ranks 1, 2, 3, etc. This should be taken with a bit of a grain of salt, but reasonable to look just from to take the broad view. The top 3 interventions, the ones with the highest probability of effectiveness, were things that had contained exposure and response prevention, including the ERP plus SSRI group. The mid-ranked interventions were the medication treatments, and then the last 3, the bottom 3 interventions were behavioral control, pill placebo, and waitlist. On the next slide, we'll talk about these interventions. So these graphs, I'm going to show a series of graphs like this. So I wanted to just introduce the picture. Focus on the blue diamond. That's the net mean difference. So the difference in the change in the intervention group from baseline minus the difference in the change in the control group from baseline is sort of a difference in difference measure in SciBox units. So the SciBox scale goes from 0 to 40. It's not clearly accepted, but people have published that a decrease in SciBox of 4 to 5 may be a clinically important difference. So the blue diamonds are the effect size with the 95% confidence intervals. Because this is a network, there are direct estimates provided by studies, and there are indirect estimates. These two bars illustrate that these are generally pretty consistent from one to the other. And then the prediction interval is the expected effect that one would see if you repeated this study in the same population. And that's typically wider than the network estimate, and it sort of can be seen as a global index of study heterogeneity. So for the SSRI versus placebo treatment, there was an effect, a net mean difference of a minus 4.4, which in TCA versus placebo, so again, effective, and then no difference in SSRIs versus TCAs. That made our clinical experts happy because they, in general, think that the side effect profile is better for SSRIs than TCAs. On the next slide. So ERP looks better than SSRIs by minus 2.7, again, with some more heterogeneity. And then a similar conclusion of ERP with SSRI versus SSRI. So the addition of ERP appears to improve effectiveness. Next slide. And then finally adding SSRI to ERP alone, fairly wide confidence interval, but get it again, no difference in effectiveness. Next slide. So in conclusion, we found consistent and strong evidence that CBT with exposure and response prevention provided either in person or via telehealth is an effective treatment for OCD. We can also conclude that both SSRIs and clomipramine are more effective than pill placebo. Overall, based on the ranking, interventions that include ERP are most effective, followed by medications. Next slide. The clinical implications of this are that, at least based on the RCT evidence, ERP is a first-line treatment, either alone or in combination with an SSRI for children with OCD. ERP delivered via telehealth is more effective than waitlist control, with effects similar to those seen with in-person ERP, supporting the consideration of telehealth as a means to increase access to care. Our review found very sparse evidence to inform how to treat individuals who fail to respond to treatment with either or both of these interventions. Yeah, this is just a flow diagram. I'll stop there unless to give time for the discussants. Thanks.
Thank you very much to Gaelen and Dale. Let's turn to our discussants, please. April Joy, will you begin, please?
Great. Another great presentation, and certainly learned a lot from the report. So I want to lift up what was shared earlier, as well as in the report. The researchers noted the need for, quote, greater representation of non-white, low socioeconomic children in future studies, as well as greater research on potential social determinants of health, or SDOH. So I'll touch upon a few of these because I think it's important for us in healthcare to still talk about social determinants of health. So first, and this is my psych epidemiologist hat speaking, the underdiagnosis and misdiagnosis of OCD. So we know that there's research that talks about children from racially and ethnically minoritized groups more likely to have their OCD symptoms either misdiagnosed or overlooked. And so what does that mean for the clinical side to understand or to obtain a greater cultural understanding of different cultural expressions of obsessive or compulsive symptoms? I think conversely, there's stigma and cultural beliefs of parents and families that we need to acknowledge. For example, like in our own population, we know that some families interpret OCD symptoms through cultural, religious, or spiritual lenses. And so this may lead to a delay in help seeking or preference for non-clinical interventions as opposed to a pharmacological approach. And that stigma still exists in different communities, which can prevent early recognition and treatment. The third is access to care, which I'm sure is clear to everyone on this call, that evidence-based treatments like those talked about, CBT, ERP, are not equitably available, particularly when we talk about youth who live in rural areas, those who are low income, or who may either not speak English or come from limited English proficiency families. And then the fourth, I'm sure we'll talk more about in terms of policy and structural barriers, in terms of insurance coverage limitations, transportation challenges, lack of school-based services. We know that specialists in OCD services are often concentrated in urban or academic medical centers. So what happens again to our pediatric population that lives in rural areas?
Great. Thank you, Jennifer.
Yes, a few things that I think about, as April Joy pointed out, is sometimes in pediatrics, when a child is coming to the office, the way they might describe what is going on with them might be developmentally what they know. So for instance, I recall in training, I saw a 6-year-old who said, well, my brain just tells me to do this. And everybody thought she was having hallucinations, yet that was the way she described OCD. So I think, for people to understand that kids might present a different way, that's something to remember. I think another thing to think about is kids with other disorders like language disorders or autism, where it might present a different way. Also, sometimes in OCD, you might actually see an avoidance as the actual compulsion that's occurring. So that avoidance might get chalked up to being oppositional or something else like that. So I think it's that recognition piece. One of the things I have to mention about the CBCL is it is a copyrighted questionnaire that would be harder for a primary care practice to probably incorporate in their flow. But it's certainly, that could be, I think, a barrier for primary care pediatricians to be able to use that and identify. Finally, I think just to follow up on the ERP piece of things, April Joy had brought up that, there are barriers certainly to being able to be present for therapy. But I think the other thing too is, like, as we consider parents as well, sometimes it's also considering how can we make sure parents aren't unintentionally accommodating children. And so they very much need to be a part of the therapy as well, which then we need to think about how can we ensure parents also can really have also the time to take off and to be present for these therapies so they're not unintentionally accommodating these compulsions and rituals.
Great comments. Thank you. Michelle.
Thank you. Again, third, so I feel like a lot of the things I wanted to say got said, and I appreciate that of my colleagues. I guess I'm going to stick with systems at this point. I mean, one of the things I really appreciated learning was that the telehealth approach was effective with youth, and it made me immediately start to think about what April Joy raised, which is this issue of inequity across our country and qualified clinicians, let alone forget the fact that we have just a lack of a large enough workforce for what we need to be responding to. Forget that. The fact that we've got, as April Joy pointed out, real hubs of expertise in urban environments and less so in our rural and frontier communities. And that this particular analysis points us to telehealth being an appropriate model. It made me think immediately of some of the systemic barriers we set up ourselves of needing licensure across, really just opening up the capacity for some of our most specialized people in the country to be able to respond to needs no matter where they are through telehealth. And so it's one of the things I think we'll talk about later when we talk about systems, but those kind of strategies are probably the best ways that we can move ourselves forward to be helpful to youth and families, ensuring that the kind of highest qualified person, most specialized person can actually respond. So I look forward to the policy and finance discussion as well.
Great, thank you. Once again, our discussions, thank you so much for wonderful comments that you've made. We're going to move on to the third report, and following that, we'll be entertaining general discussion. So please be putting things in the chat as questions are arising. But now I'd like to invite Leslie to present her report. Thank you.
Sounds great. Next slide, please. All right, this is our disclosures and disclaimers slide. We have nothing to disclose, and of course, we are funded by AHRQ and are responsible for the content. Next slide, please. And of course, we have many, many people to thank, including AHRQ for the funding and support and guidance. The APA for really recognizing the need for this review, American Psychological Association, and of course our key informants, technical experts, peer reviewers, and public commenters. I also wanted to make sure to thank our other lead authors, Dr. Zhen Wang of the Mayo Clinic Evidence-Based Practice Center and Dr. Hassan Murad. Next slide, please. All right, so really the need for this review is born out of a pretty alarming public health crisis in which suicide has surpassed cancer as the second leading cause of death for youth ages 10 to 24. And in addition to suicide deaths, we are seeing suicide-related emergency department visits increasing pretty dramatically. And since COVID-19 pandemic, we've witnessed particular increases among various groups, including males, pre-adolescents, and young adults, along with Native American and Black youth. So despite this concern, we have very few evidence-based guidelines to inform how we should work with these young people. And unfortunately, most of our current supporting evidence has been extrapolated from adult studies. Next slide. So the primary objective, of course, was to assess effectiveness and harms of treatments designed for reducing suicidal thoughts and behaviors in youth. Though we intended to synthesize data on effect modifiers, we did find little data available, so we will not be presenting that here today. Next slide. Next slide. All right, so we used established methodologies for systematic reviews from AHRQ Methods Guide for comparative and effectiveness research. I should mention we intended to do a meta-analysis, but due to a large heterogeneity in the interventions, controls, and the outcomes, we were unable to do so. So we did a narrative synthesis. Next slide. Here's our analytic framework. I just wanted to mention that we specifically included studies that used interventions that aim to reduce suicidal thoughts and behaviors, including psychotherapies, pharmacotherapies, neurotherapeutics, and emerging therapies, or some combination. We did not look at interventions designed for comorbid conditions that go along with suicide, such as depression literature, because that's already been summarized, and many youth with those conditions do not have suicidal ideation or other outcomes. Next slide. All right, so in terms of how we derived the strength of evidence, RCTs started as high and observational studies as low, and then they were downgraded based on the risk of bias, imprecision, indirectness of the evidence to the key questions, inconsistency of results, as well as likelihood of reporting and publication bias. Next slide. So based on this assessment, we assigned ratings as high, moderate, low, or insufficient. Next slide. We started with, after duplicates were removed, 28,489 citations, and we ended up with 65 original studies included in 80 articles. Next slide. All right, so in order to categorize these interventions, we developed a specific framework consisting of traditional psychotherapies. So these are treatments that were originally designed for the outpatient setting to be delivered over multiple sessions, over weeks or months, usually involving multiple treatment components and formats. But also within this category, we included adapted versions of standard treatments that were adapted for various other settings like inpatient DBT, skills training on inpatient units. Our acute interventions consist generally of single session safety planning interventions delivered in an emergency department setting, but also continuity of care interventions like rapid outpatient follow-up following an emergency department contact, or 1 to 4 session brief adjunctive treatments, usually skills-based interventions delivered via web or video. And then finally, school-based or community-based interventions are programs that are designed really to target youth from communities at risk. Oftentimes, they are culturally tailored in order to address specific risks within that community or barriers to treatment. Next slide. All right, so these are our results. Let's start with traditional psychotherapy. So we found 6 distinct types of psychotherapy. For our cognitive behavior therapy, these are outpatient treatments designed to target maladaptive thoughts and behaviors that contribute to suicidal risk. And overall, we found low strength of evidence with no difference in ideation, attempts, or self-injury. Dialectical behavior therapy, we found the second most number of RCTs. We did find moderate strength of evidence for reducing suicidal ideation and non-suicidal self-injurious behavior. We did not find support for adapted or abbreviated versions of this treatment. And I should mention DBT is a multi-component pretty intensive skills-based treatment. Attachment-based family therapy is a treatment that is designed to improve the adolescent's sense of security in the family and target family processes. We did find insufficient strength of evidence for reducing ideation or attempts. Family-focused therapy, fairly similar treatment designed for youth with bipolar disorder. This one is geared to reducing suicidal ideation and attempts by eliciting family support, insufficient strength of evidence for reducing ideation or attempts. Collaborative assessment and management of suicidality. This is a brief, scalable treatment that is safety planning intervention. So each session focuses on safety planning. We found 1 RCT, insufficient strength of evidence for reduced ideation or attempts. And then finally, we found 1 before-after study on a short-term psychodynamic psychotherapy, suggesting insufficient strength of evidence for reducing ideation or attempts. Next slide, please. Next slide, thank you. Thank you. Oh, actually, sorry, did we miss? I apologize, back. Thank you. I apologize, I didn't see a change. All right, so this I'll go through a little more quickly. The top 3 are all safety planning interventions delivered on the emergency department compared to kind of emergency department care as usual. And one is enhanced with family support for the youth to enact the crisis plan. The second is a treatment that uses motivational interviewing strategies to enhance motivation for using the safety plan. For all of 3, we found low strength of evidence consistent with no difference in ideation or attempts. Continuity of care. These are kind of follow-up phone calls after an emergency department visit or rapid outpatient follow-up, we found low strength of evidence with no difference in ideation and attempts. And then finally, our brief adjunctive interventions, also no difference in ideation or attempts. Next slide, thank you. All right, so community-based interventions, social network intervention. This is a treatment called Youth Nominated Support Team, in which a young person who is admitted to the hospital identifies a supportive person in their community who gets trained to provide social support. So potentially very scalable. Unfortunately, no low SCA, low strength of evidence, consistent with no difference in attempts or ideation. Our school-based skills intervention, these are typically CBT type interventions delivered in groups within the school setting, found also low strength of evidence with no difference between a comparison school in suicidal ideation. And then our suicide awareness gatekeeper programs, these are programs designed to educate youth on the red flags for suicide so they can better identify suicidal risk in themselves or others, and then they get linked to services. And also low strength of evidence, no difference in attempts. And then finally, community-based culturally tailored programs are preliminary at this time with low strength of evidence, no difference in suicide ideation. All right, next slide. Okay, so just in terms of just some general takeaways about these treatments, for CBT, we did find the most RCTs, and these were very well designed interventions, multiple components that were designed to target specific risks found in the literature for suicide in adolescents. They recruited very high-risk patients coming from very acute settings, but unfortunately not superior to treatment as usual. Dialectical behavior therapy, the samples were predominantly female, but a diverse population of patients. We did find moderate strength of evidence for DBT, but only as the treatment was designed as a multi-component treatment rather than the abbreviated formats. Attachment-based family therapy also recruited very diverse, very high-risk patients. Many of these treatments were specifically tailored for the needs of diverse groups. Though it was more effective than treatment as usual, it was not more effective than a non-specific family therapy, suggesting that perhaps family therapy is the active ingredient. Collaborative assessment and management of suicide, though that was a predominantly white sample, they did have more males than most intervention trials for other interventions. It was not superior to treatment as usual, but they did find that lower risk patients did better, which makes sense as it is designed to be a pretty brief scalable treatment. All right, next slide, please. Okay, so interestingly and surprisingly, we did not find any benefit of safety planning over usual care, and even when it was enhanced with family support or motivational interviewing. However, for the family-based crisis management, we did find lower rates of hospitalizations, which might make sense as families might feel more comfortable taking these young people home rather than having them be admitted to the hospital. And then for our adjunctive interventions, though, there was only one that actually was associated with a significant reduction in suicidal outcomes, and that was a 4-session trauma-informed treatment that was delivered on an inpatient unit, and then utilizing technology after discharge to remind people to utilize the skills. Next slide. So our youth nominated support team, though at study follow-up, they did not find any difference with treatment as usual. A secondary analysis looked over a longer period of time, 11 to 14 years, and they looked at death records. They found significantly fewer deaths in those youth assigned to youth nominated support team. Though our gatekeeper programs did find that youth were likely to report risks in themselves and others, it did not translate into reducing other suicidal outcomes in general. And CBT-based skills delivered in the school were similar to some of the findings for how they're delivered in outpatient settings. And then, of course, we need more study on our culturally tailored interventions. So next slide. All right, I think what was really surprising is the lack of any studies on pharmacological treatments for youth with suicide. There was one study that initially was designed as an RCT to compare combination to medication only and CBT only, but they could not recruit for the single arm studies. So they ended up just looking at the results for the combined treatment. Though we think we might be able to extrapolate from some of the trials from comorbid conditions, such as SSRI trials for depression, most of the suicidal youth were excluded from those trials. So really at this time, the effectiveness and harms of pharmacotherapy for suicidal youth is really uncertain. Next slide. All right, we intended to do a network meta-analysis to look at various effectiveness of different components. We were unable to do so due to the limited RCTs, but we did look at, you can see here, these are some of the top included treatment components. They very much overlap between various interventions, and you can see most involves some emotion regulation skills, followed by safety planning, cognitive restructuring. Next slide. So just in terms of what do we take away from this, I mean, I think a clinician can be very confident that the literature was really representative of marginalized and pretty significant, or adolescents at pretty significant risk for suicide, though mostly female identifying and of adolescent age. So we have less information on young adults, pre-adolescents, and males. Though, you know, there was little evidence for psychosocial interventions over treatment as usual, we need to understand that suicide research, probably more than other treatment research, is beholden to ethical principles to ensure that both groups get adequate care. So the treatment as usual was really optimized with education, phone calls to help with family problem solving. They were also likely referred to skilled clinicians in their community known for treating these youth. We also know that the treatment components have been widely disseminated for other treatments. So it is possible that perhaps treatment as usual did not look that distinct from our experimental treatments. And then we want to consider how common factors might be responsible for some variance in outcomes. Just surprisingly, that safety planning did not outperform usual care. And it's likely that treatment as usual involves safety planning, but also I just want to consider how, as someone who works with eating disorders, when my patient comes in a suicidal crisis, all therapy stops and we are focused on safety planning. So that is, we don't get as much therapy accomplished. So it might crowd out some other important therapeutic strategies. And then actually, next slide, just for the sake of time. Thank you. And then next slide. All right. So of course, a lot of limitations that's inherent in this research at this time. We only found of the whole, all of our studies, only 42% represented RCTs. We were, of course, unable to conduct the meta-analysis. I should also mention that many of the RCTs were feasibility or pilot studies, so were very underpowered. The follow-up periods were often not long enough to really assess rare and distal events, such as suicide attempts. We rely on self-report measures, and this may not fully capture internal suicidal distress. And next slide. Oh no, then I'm for future research. So of course, yeah, next slide. I apologize. So of course, we know that this study really identified very important gaps that can help inform future research. Some of these we've kind of self-explanatory. We currently do not have any idea of which treatments work for whom. We need to look more at males, latency age, young adults, those with neurodiversity, externalizing disorders. And then there's a number of innovations in research methods that can help us identify effective treatment components, as well as help us better assess suicidality, such as wearable technology. So with that, I will close.
Great. Thank you very much, Leslie. Let's turn to our discussants, and we're going to do it the reverse order this time. So Michelle will have a chance to go first. So Michelle.
Thank you so much, Lucy. I actually appreciate this so much, and I want to kind of dial in on the future research and innovation section that you just listed. I'm sure everyone on the call is aware of the massive investment the country's made in 988 implementation, and we see across the states a number of probably half of our states standing up a mobile response and stabilization models, particularly focused on children, which would allow for, one of the key hallmarks of that is to think about the person identifying the crisis. The goal with kids and families is to go further upstream. If you as a family or you as a youth think that, you're not settled, really is as easy as it needs to be, then these calls and these responders, these first responders, are available to you. It's not nationwide yet, but it is coming based on the efforts that both CMS and SAMHSA have put out. And I think I'm just thinking about that future research opportunities of really helping folks who are doing that training, technical assistance, and workforce development learn from the work that you just represented to us and embed that in capacity, because more and more I think we will see youth and families calling for mobile responders to come into their homes. That's the goal here, right? Versus going to an outpatient, going to an emergency department, really trying to move into a school calls you go, a home family calls you go. And so there's so much that we still need to learn in this space and continue to hone, particularly given the significant financial investment the country's making to really make the whole system look different, more public health related in terms of its response for children who are at risk like this. So I look forward to that. I think that the states actually have the data we need to be compared and contrasted and outputted. And so it'd be great to partner with people again, moving this forward to think about different, what our crisis system is really evolving to. Yeah.
Interesting. Thank you.
Yeah.
Glad I let you go first. Michelle. Oh, I'm sorry, you are Michelle. Jennifer.
Thank you. When I think about risk factors that might contribute to suicide risk, I think about community and societal structural factors. I think about maybe their own, an individual's own relationship factors, and then I think about an individual's own factors. And oftentimes the patient population I see might be people that might have neurodiversity. So whether they have intellectual disabilities, specific learning disabilities, language disorders, autism, there might be a different approach for those individuals. And I think that probably is also something to consider, especially as we think about, some of these helps that are organized at a higher level. Is it a developmentally appropriate approach to some of these other individuals that have a much higher risk? Thank you.
Great, thank you. And April Joy.
Great. So great job in terms of laying out the different, I should say, limitations in what we know about the management of suicidal thoughts and behavior in youth. I will lift up just a few more gaps in the evidence base as well as opportunities. So one, I think a lot of the interventions that we know of focus on the individual level of symptoms and not really taking into consideration that those upstream causes like poverty, like housing instability. And so for research to really link social determinants of health to suicidal outcomes and test multi-level interventions that encompass policy plus the individual plus community. I will also say, having spent a couple decades in the mental health research space, we are still very much a deficits-based approach, and I think it's important to lift up cultural strengths and resilience, to look at, I had talked about earlier cultural stigma, but actually there's also spiritual beliefs, family values, values of community that could actually serve as protective factors in reducing suicidal risk. And so what does that mean for research to better integrate asset-based approaches to identifying and integrating cultural and community strengths into care models? I know it was also brought up different research methods. So looking at implementation science, particularly in underserved settings. So we know that while there is evidence-based practices that do exist in terms of guidance on how to implement them in low resource diverse settings like the one I work in, so FQHCs, think about tribal health clinics, and so the need for studies on feasibility, acceptability, and scalability of suicide prevention models in real-world settings. The last part I'll bring up, because it was brought up at the end of the presentation, is youth-led and participatory research. I know in the disabilities movement, they started the thing, nothing for us without us. And I think often youth voices are often excluded from the design of interventions that are intended to serve them. And so what does it mean to uplift more participatory research methods that allow youth to serve as co-researchers, even co-designers of interventions that reflect their realities?
Great, thank you to our discussants. Wonderful, wonderful points making. This is now the audience participation portion of the agenda. So we encourage you to chat in questions or raise your hand if you'd like to speak out. We'd invite the questions, but I'll go ahead and kick things off. And first I'm going to turn to Susanne and Bradley and the ADHD Diagnosis and Treatment report. And I'm just wondering, what stood out to you as the biggest disconnect between research studies and the realities of clinical decision making? And in particular, how can future studies be more useful in the real world care or ADHD?
Yeah, Brad, do you want to go ahead, or do you want me to go first?
Why don't you go, Susanne, and then I'll join in.
Yeah. So, I mean, we looked at a lot of different things, but for the diagnosis, I would definitely say that so there is a lot of academic research and there's a lot of data, but oftentimes these are not data presented in a way how these tests would be used in practice. So usually they, what we saw is a very sophisticated machine learning supported models that try to optimize how to differentiate in this particular sample. So that's very different from how tests would be used, in clinical practice. For the intervention studies, what was shocking to us was that so people are very concerned about treatment effect over time and whether children especially stick to the intervention. And we've included 300 studies, and literally a handful of studies had data beyond 3 months.
Yeah, I agree with all those points and concerns and sources of disconnect. I think the absence of long-term outcomes is really shocking and very problematic and very limited in the scope of the outcomes assessed, primarily ADHD core symptoms and little else. And then almost, next to nothing in terms of adherence issues long-term. And I think as clinicians, we all struggle with that, especially with medication, but really for all treatment modalities. Many of the studies, especially treatment studies, but also diagnostic studies, really weren't conducted in real world representative sample populations, and that's a real problem. And then maybe the most problematic is that there are virtually no, well, very, very few head-to-head comparisons between treatments of major interest and that are needed in terms of really informing for clinicians, parents, and kids which treatment may be the right one for them.
It leads me to a follow-up question as you think about sort of the temporal nature of the outcomes over time and the shortcomings you've noted in the observed literature. But I'm wondering, can you identify any infrastructure or policy changes that would help to support that kind of research? Because we have such a fragmented healthcare delivery system that disrupts, the continuity of the data.
Yes, so, I mean, maybe I'll chime in first, but I think having, certainly in published studies and funded studies and controlled studies, we really need to insist that the data are put in public repositories that everyone can access for secondary data analyses, but more importantly for meta-analyses.
Mm-hmm.
So that you've got much larger and more representative studies, so you can see what generalizes across populations. And again, it's both for diagnosis and treatment, and really we don't have them. It also allows you to look for moderating effects that will tell you for which kinds of patients do treatments work better. And ultimately we need that for personalized interventions, for a young kid who's a boy who has severe symptoms and a lot of impulsivity, for example. So without those meta-analyses and public repositories, we will never get to those answers. And the data are available. I think that's a real clear policy intervention that should be pushed and pushed hard.
Great, thank you. Susanne, did you want to add anything to that?
I mean, just to say, I mean, we do have the technology now, right? So we do have, we should leverage, electronic healthcare records. We should leverage this for, just tracking better, both on the assessment side and also, on the treatment side. And I mean, we didn't mention it with the monitoring studies, but when we prepared the topic, all our key informants were so very, very enthusiastic about the question and said, yeah, this is exactly what we need. We don't know which strategy we should use. And then we find hardly anything.
Yeah, I might follow up really briefly. I think in terms of, well, outside clinical trials and funded studies being in public data sets, I think also patient registries that have uniform, publicly available, standardized assessments that with core assessments that can be online, patient data entered and stored and analyzed across settings would be really important. And making those assessments, online assessments, available. A prior comment was that the CBCL is patented and not affordable. Well, we should come up with a publicly available CBCL that can be used in this kind of way. And there's a lot of evidence that diagnostically it performs as well or better than anything else. And not just for ADHD, but for other conditions that can be confused with ADHD. And it can be used for monitoring as well for symptom change. So I think those are also policy level developmental interventions and processes that can be put into place.
Great, thank you. I see there's an interesting comment from Dr. Margot Adams. Margot, do you want to come online and share your comment with us? Margot, are you there?
Can you hear me?
Yes, we can. Thank you for joining in.
I'm not sure if I am, I have two screens, so I don't know which one has my camera on it, but I have found this entirely intriguing and appreciate all the presentation and conversation. When I first started my career, I started in the world of ADHD, and I've kind of come full circle and also been researching in the area of OCD and have really recognized some of the significant challenges that we have, not only in the areas of research, but the application and the transition from research into practice. And I think that's what the last speaker was saying with regard to the child behavior checklist, which of course is a gold standard. It is available to folks. It's just not freely available in terms of it costs something to utilize. And so it's not easy to integrate into our current nowadays electronic health systems and records, and yet that's just like the tip of the iceberg challenge. I think we have a lot of others making decisions in terms of healthcare that we haven't even addressed in this conversation related to insurance carriers. And so for those fortunate to have insurance coverage for some of these services, those carriers are making decisions about how many sessions, about who can provide it, whether the medication is, which tier it is in your pharmaceutical repertoire for what you can provide or what you can receive. And so I think we have so many systemic or kind of larger systems that play roles in this that it's very difficult to really assess when we're thinking about the research protocols. And my only other, thing that I would say from my comments is in our research protocols and what gets funded is the content of the actual treatment. And very often we don't have funding to continue that connection with the participants to be able to get that follow-up data. And I think that's really a challenge for many of these that we see either, the participants move or the funding is lost in terms of whether it's a school-based intervention or connection. And so it's very difficult to do that long-term research. And particularly when we look at some of the pharmaceutical interventions, sometimes things stop working. And so we've lost contact with those patients, maybe in terms of what's happened with kind of the protocol that they've been on in terms of an RCT or something like that. So thank you so much for the opportunity to share.
Thank you for chiming in. We appreciate your comments. Let's turn now to Gaelen and Dale's work on diagnosis and management of OCD in children. And I'm just wondering, as you contemplate, what you've presented to us, your review found exposure and response prevention, or ERP, to be effective for symptom improvement. But how should we measure treatment success in OCD?
I'll take that on at some level. I think, we meta-analyses are often dependent on the measures that are used and reported, and clearly symptoms are important, but patient-reported outcomes and teacher-reported outcomes and parent-reported outcomes are all highly relevant. There are, as you all know much more than I, there are a plethora of scales. This may be an area where it may be important to identify common outcome measures for use in clinical practice that get at those dimensions.
Gaelen, anything to add?
Not per se, because Dale actually works in this field as well. I think that the only thing I would add is that one of the things we really didn't see was sort of this whole what works for whom, and I think that also gets in the way of sort of knowing what is success, because it may differ across populations.
Yeah, one of the things I thought was intriguing in your results was the combination of therapies that had greater improvement results. And I'm wondering, did you see any studies reporting on like N of 1 trials where you were sort of titrating the different treatments to really tailor individual needs?
I don't recall any formal N of 1 trials. that we identified in our search.
Mhm.
Certainly, that's in part what practitioners do.
Right. But I think it gets at some of the issues that Margot was raising around, like the role of insurers in determining which types of treatments are available and over what time period those are available. And so that's an opportunity sometimes in those trial designs to partner with payers in testing the therapeutic options and tailoring it to the patient's needs.
I would comment that, the numbers of participants enrolled is actually very small. And to have large pragmatic trials that are really powered to identify treatment effect modifiers would require, significant larger sample sizes.
Right. Good points. I'm not seeing any other comments here, hands raised. Elizabeth, if you see something I'm not seeing, please let me know. Why don't we turn to Leslie's report on management of suicidal thoughts and behaviors in youth. And Leslie, we have a series of questions we had in advance, but one is, considering the limited research on combined psychosocial and pharmacologic interventions, what do you recommend for future studies to better assess the efficacy of integrated treatment approaches? Leslie, are you there?
So sorry.
That's okay.
Yeah, no, it's very challenging because I think to recruit for a study that can really compare a combined, pharmacotherapy, psychotherapy to, single arm treatments. It's really difficult to recruit. And I think it's because most people think it is mandatory treatment to have medication. They think it's, the widespread assumption that these are life-saving medications. So it would be difficult for people to do, just the CBT arm alone. So in terms of it's something we need to do. We need to be able to do these studies so that we can understand the benefits and or potential harms, particularly for this higher risk group and the context of small but statistically significant increase in suicide in the treated group over a placebo group in the depression trials. So something we need to understand.
Great. And I was also wondering, as I was listening to you, that given the rapid evolution of digital and telehealth platforms for delivering interventions, how do you anticipate these modalities impacting future research priorities and methodologies in the field?
Yes. I'm less enthusiastic about digital interventions that are without any human contact. Just because I think our youth are on technology overload, and it'd be hard to really have an impact. And I do think that a lot of these young people, one of the things that characterize them is they do feel alone in their suffering. So needing some human to facilitate the technology, whether it be telehealth, but finding those, we need to develop adequate psychotherapeutic interventions that are effective, and then disseminate those via telehealth to improve access.
That's great. Thank you for that thoughtful comment. I'm going to hand it off to Elizabeth now to moderate a focused discussion on, the report's implications for policy equity and health systems with our discussants. Elizabeth.
Well, thanks very much, Lucy. And it was wonderful hearing from all of the report authors and diving into that in a little more detail. I do want to turn to our discussant colleagues, April, Joy, Jennifer, and Michelle. And maybe what I'll do is I'll start with focusing on the report that was focused on management of suicidal thoughts and behaviors in youth, since that's sort of where we are at the moment. So instead of jumping us all back, I'll start here and just kind of open it up for folks. I want to like harken back to a few of the comments. And so as we think about kind of the rising rates of youth suicide, and also the gaps in the evidence base that were articulated a bit by Leslie, as well as your collective remarks, kind of where do we see opportunities on the horizon? So here I'm kind of hoping to actually build on some of your comments earlier in terms of thinking about those asset-based approaches and the role of implementation science. As well as how we build on the strengths of our public health and data systems in the states that we're already seeing. So I'm thinking here in particular to comments that were raised by both Michelle and April Joy, but I want to just open it up to you all. So maybe that was unfair and unkind. Let me go to Michelle first here, since she has the unfair advantage, disadvantage.
That's what you get when you take your husband's last name. I never should have done it to be the Z in the room. So that was a lot of questions. And so I'm going to answer it how I want. Is that okay?
That's the best when I deserve it, all of it.
Yeah. So I guess I do believe that the effort that has been a bipartisan effort to stand up 988 and establish financing, better financing for response models for young children through adults is an important context for all of this. And so I think that the lack of evidence or the emerging opportunities for better evidence have to all be contextualized almost in a different world even, right? So we're still struggling with like clinical guidance for practitioners and workforce training approaches that are effective. And now we're asking lots of people to pick up and move into people's homes and into schools and communities. And so I think just the opportunity for the research is very profound with what we know now. What I do worry about is that even with parity acts, we do not see states necessarily standing up comprehensive models that are for private insured children and publicly insured children. And I think all of us, it behooves all of us to really acknowledge that a lot of times publicly insured children have access to far more comprehensive services and supports than when you have private insurance. And a lot of times the models that states are standing up that are, early childhood mental health consultation and so on are identifying children that we know to be at risk, and people are carrying forward with those kids with care coordination. Nothing is perfect in a public system, so don't misread me. I understand how bad our data are, but the holding tank is a little more aggressive in trying to help those kids than you see in public insurance. And so I don't know how we get to better research, better kind of, I'm going to talk about it as systems framework versus an actual intervention, if we don't just fully engage our managed care systems and train our states when they're purchasing, when they're using public dollars, or they're allowing licensed entities to come in and insure. I think about Massachusetts as an example of a state that's trying to really require its private Medicare or private managed care companies to offer equitable services for private insured kids as they would its public. Like there's just a big, huge structural evolution that has to happen. And we have a lot of money in managed care in this country. So as we're debating and like trying to figure out how to do better research, gather the information, train our workforce, there's money stuck in certain parts of our industry that need to be better engaged to do better work. And I don't even know if I fully answered your question, but that's my answer.
Well, we established that I asked 30 questions. So
You did. So that's my answer. And I'll jump back in if April, Joy, or anyone says something that I want to add to.
that was wonderful, and I actually really appreciate the points about sort of the role for managed care to be playing in this.
Yeah.
But let me come to April Joy next.
Yeah, so I will answer one of those questions. Yeah, in terms of funding priorities, just to build on what Michelle was talking about, right? I think we have a very siloed approach, right? Michelle already talked about the fragmented approach we have to youth and that very siloed. And so one funding priority I would note is establishing local or regional youth suicide prevention collaboratives, right? So where do youth spend most of our time, right? So how do we better engage schools, healthcare providers, juvenile justice, child welfare, community organizations, creating funding opportunities for shared data infrastructure and protocols. So I've learned this alphabet soup. So HIPAA and FERPA. So FERPA is like the HIPAA, but in the schools. And so I think sometimes it's not a matter of collecting more data. It's having those who are collecting the data having their systems talk with each other, right? And so how do we create HIPAA and FERPA compliant platforms to allow for real-time exchange of information across systems, right? So schools notifying behavioral health providers of risk flags, right? Developing interoperable data systems that link schools' data to HRs, to child welfare, to juvenile justice databases to track risk indicators longitudinally, which then, Elizabeth, gets to your other question, so that we can do that longitudinal research and follow up, right? Not this one and done suicide prevention, but also early intervention and then what happens in follow up. And then I would think the third is we need people on the ground, right? We need mental health professionals, not just within the four walls of clinical practice, but also in schools, in juvenile justice facilities, and child welfare offices. I think we can learn a lot from the work that's been done in social determinants of health and the use of blended and braided funding models, and to sustain these positions and other efforts in this space, particularly when working across systems.
And I just want to piggyback on that. That is a really excellent place for either research hubs, however they're structured, or academia to partner with state government, because the capacity of state government to sustain that model that April just pointed out, that's a real data infrastructure and translational opportunity for people, it will always ebb and flow with party changes and just elected official changing. And so as I've seen this across the country, at least, those kind of infrastructure models for data usage and linking are phenomenally informative and impactful for state. Like a lot of our good government states have those and they use those to the best of their ability, but having it embedded inside of the purchaser, the state system, super hard to maintain over the years. So that's a great place for researchers such as yourselves that have joined this call and clinicians to, set it outside on behalf of state government. So
that's a nice call to action for the folks that are here, I think, which is great. I want to just see, Jennifer, if there are any ways in which you would like to weigh in or build on any of the comments of your colleagues here.
Yeah, so I think about as a clinician, if you saw this patient in your office that has this risk, you want to think about how you can help them. And so as you're thinking about access, oftentimes, especially in more rural areas, you're going to say, whatever access I can get is better than none. But I think we also have to step back and say, well, is this quality care that, has the same level of these studies of, properly executed therapies and things like that. So I think also thinking about quality care as well for the treatment, so that we don't do harm, even though the intent is good.
Great, thank you. I'm gonna pivot us a little bit to move to the thinking about what we heard as it relates to diagnosis and management of obsessive compulsive disorder in kids. And here I'm actually going to start with some comments that, Jennifer, that you had made in your comments. So as we were thinking about the different tools that have been developed to assess OCD, I know, we heard is that not a ton of them there's not a ton of evidence to support some of their use, but also in terms of some of the tools, as was mentioned by you, Jennifer, one of the tools in particular is licensed in a way that can also limit access to it by those in primary care. And so when we think about what implications all of that might have, and what role maybe either policy or others can play in addressing some of those implications. So maybe I'll turn to you first.
Sure. When I was thinking about this, I was thinking about when people were trying to implement developmental surveillance and screening. And I'm trying to think, I think those guidelines came out in 2009. My mentor was one of the main authors on those papers. And there were just so many elements that the devil's in the details, right? So how do you purchase the system? How do you ensure that the parent completes it? Who's going to score it? How are you going to fit it in a 10-minute visit to talk about these things? And then what are you going to do when something scores positive? So I think there's a lot of implementation things to think about. And then on top of that, that's just implementation. How about getting paid for it too? There certainly were policy implications for that. So I think we have to think about, what are the policy implications for if you're going to do some screening in your primary care office, who's going to help pay for it, who's going to help do it, how's it going to be a part of workflow?
Great, thank you. And I want to just get maybe some of the policy, and I think, Michelle, you had mentioned in your earlier comments about wanting to sort of come back around to the policy and financing aspects. There's maybe some of the systems thinking and financing aspects of some of these issues. So wanted to open the floor to you.
Yeah, and I kind of said it already, but I'll repeat myself. Like, I'm kind of here focused on insurance models right now as purchaser, right? That there's so much of successfully doing any of these things will take some level of negotiation with how managed care works right now. But this licensure level, I really read and reread, so thank you, the information regarding telehealth as an effective model for OCD treatment, right? But we really are stuck in a system. We've got one or two ways that clinicians who are subject matter experts in very specific areas could be licensed and available to be funded through insurance in multiple states. But we've so state-based our licensure approval that it limits capacity for rural and frontier communities, tribal communities, to get access to really, solid experts. And so I do think that with telemodels, we've shown where they work. We're still researching, but that's something we've self-imposed, that we can actually step back and rethink and lobby around. It's another kind of call to action. Like, if we've got rural and frontier communities who can't access the most expert people for their children, and we've done that because of licensure requirements or the way panels are set up for managed care, those are human decisions that got made that may probably need to be reopened. So far I've taken on managed care 3 times right now. So there you go.
Well, thank you for doing that. All right, so let me come to April Joy. I know you had raised a number of issues for us to be thinking about when it comes to thinking about different communities and the way that different communities experience these conditions, and how we should be thinking about that when it comes to assessment and diagnosis and treatment. And so just want to give you opportunity to build on some of those comments as it relates to equity and speaking to different communities.
Yeah, I think Michelle and Jennifer covered a lot of it in terms of parity and ensuring, right? Like, the head is part of the body, as we like to say in mental health. And what does it mean to have parity in mental health coverage? And then different types of insurance, right? So Medicaid, Medicare, private insurance plans, Are there specific billing codes to ensure proper reimbursement and avoiding undercoding? And are we also increasing awareness among providers to use these billing codes, which I know can be a challenge sometimes? So since I brought up the workforce, I think also understanding that there continues to be a mental health workforce shortage, right? And so I think that's across the three areas, not just in OCD, but also if we're thinking about underserved populations, what does it mean to incentivize trainings, right? Through loan forgiveness, continuing education credits, which I'm sure many of you are getting right now by being at this session. Funding for training programs for psychologists, social workers, and other mental health providers, particularly in underserved areas. I also want to lift up task sharing models, which we didn't really talk about here, but given the mental health workforce shortage, a lot of work that we do in these areas can be done by paraprofessionals or those or non-specialist providers, right? We talk a lot about community health workers, peer navigators who have shared lived experiences as the communities that we're working with. And so what does it look like to embed them within the care team? And then the last piece I'll raise is, and Elizabeth and I share, training in public health. And we talk a lot about patient empowerment and allowing patients and families to take control of their own health. And so being able to fund campaigns to educate the general public, in this case about OCD, the effectiveness of ERP, reducing stigma, I think allowing them to be in the driver's seat of their own health and not just relying on what their healthcare teams or respective providers share. So really coming prepared. As one had put it here in DC, when meeting with the doctor, it should be as if you were meeting with a lawyer. And I think there are synergies because you come prepared because they're billable hours. I think if we treated it that same way of being able to come into a visit prepared would just help with leveling the power dynamic.
Great. Thank you so much. And I am mindful of the time. I really do want to thank you all for these wonderful comments and discussion. I think that what I will do though is come back to each of you for just kind of like your closing parting thought that you want to leave with folks. I think we heard some incredibly important reports today. I think we had some great discussion. And I just want to come back for just kind of like a closing thought from each of you. And I will start by coming to Jennifer.
So this is a little stolen from April Joy, but in my field, I think we often think about how to approach things from a strengths-based perspective. And if we can keep that in mind, and also how do we elevate that up to the policy level, that we can do that too.
Wonderful, thank you. I will come to April Joy next.
Yeah, so when we're thinking about different treatments, I think in public health, policy and systems, we just think what works for whom, but who can get access, who can get what works, right? And so should also in our research and our policy and in our practice, breaking down structural barriers, looking at improving early access, early timely access, and ensuring culturally attuned delivery and not just focusing on the treatment itself, but ensuring equity and opportunity.
Great, thank you. And then I will come to Michelle.
I would say ditto to all those things. Those heartened me. And I would just call out that we are living in a time where money is moving out of our system, and that these systems were built not based on children's needs, and that this is not a time to lose ground with that. And so as we lose money, the likelihood that decision makers take away from children first is the way our country's always run. And I would just call people to be very vigilant right now. We have parity on the table, Medicaid's on the table. We don't have equity across our other insurances. So I don't mean to end it negatively, but it is a moment to fight for our next generation and the generation that we're serving right now. So
thank you. No, these are important comments. So thank you very much. And so I know we are coming quickly to the end of our time together. So I just want to say thank you again to everyone so much for joining us and for participating in today's conversation. Thank you also to the report authors, in particular, Susanne, Bradley, Leslie, Gaelen, and Dale, as well as our discussants, April, Joy, Jennifer, and Michelle, as well as our partners at AHRQ and the SRC. And so I can see already, I think Taylor has jumped in there to share the CME survey link in the chat. So for those who are interested in seeking continuing medical education credits, please follow that link. And we will be sharing the meeting's recording as soon as possible and announcing the next Grand Rounds theme shortly thereafter. So please stay tuned for that and please make sure that you all have a great rest of your day. Thanks, everybody.